BPC 157. BPC 157 is the peptide most people connect with tendon and ligament recovery, because connective tissue doesn't heal the way muscle does. Muscles have a much denser blood supply than tendons and ligaments. And that is exactly why a rotator cuff tear can take many months to heal, while a quad strain can settle much faster. At the biological level, BPC 157 is a pentadecade peptide, meaning a peptide made from 15 amino acids. It comes from a protein found naturally in the stomach lining. Its main repair mechanism starts with angiogenesis, which means the formation of new blood vessels. When new blood vessels form near damaged tissue, more oxygen, nutrients, and repair signals can reach an area that normally has poor blood flow. In 2006, an animal study published in the Journal of Orthopedic Research recorded improved Achilles tendon to bone healing in rats after BPC 157 administration. And this part needs to be said clearly. These were rats, not humans. Human clinical data for connective tissue recovery is still limited, so the strongest evidence here is still preclinical. Personal athlete reports often describe recovery windows shrinking by weeks, but the real point is not the stories themselves, the point is the mechanism behind why people are interested in it. Training can strengthen tissue over time, rest can reduce load, but neither one directly creates new blood vessel growth inside poorly vascularized tendon tissue. And that is the specific effect people are chasing with this peptide. Tesamorelin. Tesamorelin is different from most fat loss compounds because it doesn't hit every tissue at once. It doesn't mainly target subcutaneous fat. It doesn't target lean mass. And it doesn't work by disrupting appetite, cortisol, sleep, and training performance all at the same time. And this is why its target is so specific. Tesamorelin mainly reduces visceral fat, which is the deep abdominal fat stored around the organs. This is different from subcutaneous fat, which sits under the skin. And that difference matters because visceral fat is more strongly tied to inflammatory markers, insulin resistance, and cardiovascular risk. In 2007, a phase 3 trial published in the New England Journal of Medicine recorded a 15.2% reduction in visceral fat over 26 weeks in patients with HIV-associated lipodystrophy. Lean mass was not measurably lost. And in 2010, the FDA approved tesamorelin for that same condition. PT141. PT141 is different from Viagra and Cialis because it doesn't start with blood flow. Viagra and Cialis help increase blood flow to a specific area, but arousal still has to be present first. They support the physical response after the desire signal is already there. At the chemical level, PT141 is also called bremelanotide, and it works as a melanocortin receptor agonist, meaning it activates melanocortin receptors in the brain. The main receptors here are MC3R and MC4R, which are found in the hypothalamus. And the hypothalamus is one of the brain regions involved in sexual motivation, not only physical response. In 2019, the FDA approved bremelanotide for hypoactive sexual desire disorder in premenopausal women under the brand name Vyleesi. And this matters because the approval was not for blood flow. It was for low sexual desire. That makes PT141 one of the few compounds in this category where the regulatory path was built around libido itself, not only the physical response. But there is one catch. The approval was for women with diagnosed hypoactive sexual desire disorder, not for general performance enhancement. And when men use it for low drive, they are usually using the same brain-based mechanism, but in a different clinical context. GHKQ. GHKQ is one of the anti-aging peptides that doesn't work through only one pathway. Most compounds in this category have one main target, such as collagen, inflammation, wound repair, or skin texture. GHKQ affects several of those systems at the same time. GHKQ levels are highest earlier in life and they gradually decline with age. And that matters because copper is not just a random mineral here. Cells use copper for enzymes involved in tissue repair, collagen formation, antioxidant defense, and inflammation control. But there is another part that makes GHKQ unusual: gene activity. Research on gene expression has shown that GHKQ can influence over 4,000 genes connected to tissue repair, collagen synthesis, anti-inflammatory signaling, and stem cell activation. In wound healing studies, GHKQ has been shown to support collagen production and faster tissue closure. It can reduce activity in enzymes that break down connective tissue while increasing signals connected to rebuilding it. If any of these peptides already sound like something you've been looking for, write in the comments which one fits your problem best. That tells me what to cover in more depth next. TB500. Most injury treatments target the specific site of pain, but TB500 targets the system that controls how tissue migrates and rebuilds itself across the entire body. TB500 is a synthetic fragment of thymosin beta 4, a protein present in nearly every cell in the human body. Its primary role in healing is regulating actin, the structural protein that forms the scaffolding of cells. And when tissue is damaged, cell migration to the injury site depends on actin polymerization. And TB500 directly accelerates that process. It reduces inflammation at the injury site without globally suppressing immune function, promotes new blood vessel formation, and according to research, reduces scar tissue formation during healing. And this matters more for long-term function than simply closing the damage quickly. TB500 is currently in human trials for cardiac repair and stroke recovery. Most painkillers only mask the signal, but TB500 works on the mechanism behind why healing stalls after the initial inflammatory response. Retatrutide. Ozempic is a single receptor agonist. Tirzepatide hits 2. Retatrutide hits 3 at the same time, and the phase 2 trial data doesn't look like anything published before it. Retatrutide is a triple agonist that targets GIP, GLP-1, and glucagon receptors. GLP-1 reduces appetite and slows gastric emptying. GIP amplifies insulin response and acts directly on adipose tissue. Activation of glucagon receptors increases energy expenditure at rest. And all 3 independent fat loss pathways run in parallel. In phase 2 trials published in the New England Journal of Medicine, body weight dropped by an average of 24% over 48 weeks. No other compound studied in humans has shown that number. A 220-pound man losing weight on that trajectory would drop roughly 53 pounds, mostly fat, with lean mass largely preserved in trials where it was tracked. Honestly, the results look like they were fabricated, but that is not the case at all. Retatrutide has no regulatory approval as of mid-2026. Trials are still ongoing, but the mechanism is validated, peer review is complete, and 24% is still 24% regardless of what the FDA timeline looks like. Diet and training can activate 1 fat loss pathway, precision dieting can push 2, but not 3 at the same time, and not at this magnitude. That is the ceiling you are working against without it. CJC 1295. Every growth hormone releasing peptide has the same limitation. The GH pulse it creates lasts a few hours, then drops back to baseline. You inject, get a window, return to baseline. CJC 1295 with DAKE solved that problem. CJC 1295 is a GHRH analog modified with a drug affinity complex. The DAC modification lets it bind to albumin, a carrier protein naturally present in the bloodstream. Albumin protects it from enzymatic breakdown that extends the half-life from minutes to roughly 8 days. Downstream effects include improved deep sleep architecture, enhanced muscle protein synthesis, accelerated fat mobilization over time, and faster tissue repair. All consistent with what sustained GH elevation produces when it routes through the pituitary rather than bypassing it. CJC 1295 is typically combined with ipamorelin, which amplifies the peak of each pulse while this peptide holds the window open. Injecting GH directly suppresses pituitary function over time and triggers receptor downregulation. 1 injection per week, routed through your own gland, avoids both problems. Gonadorolin. Every testosterone replacement protocol eventually creates the same downstream problem. Exogenous testosterone signals the brain that production is covered, the pituitary reduces LH output, the testes receive no signal, so they atrophy and natural production stops. Gonadorolin is synthetic NRH, the gonadotropin-releasing hormone the hypothalamus uses to initiate the entire testosterone cascade. It signals the pituitary to release luteinizing hormone and follicle-stimulating hormone. LH signals the Leydig cells in the testes to produce testosterone, while FSH drives sperm production and gonadorolin replicates that first signal in the chain. In men on TRT, gonadorolin administered at low frequency keeps the hypothalamic pituitary gonadal axis partially active. The testes continue receiving the signal that production is expected. Testicular function is maintained, fertility isn't automatically forfeited. In 2021, a study published in Fertility and Sterility found that men using gonadorolin alongside TRT maintain testicular volume and sperm production markedly better than men on TRT alone. Most TRT protocols don't include it. That's either an oversight or the reason why so many men on long-term TRT find the exit ramp much more complicated than the entrance was.